Um, Welcome to the Monday meeting of Cardiac Anesthesia and Critical Care Forum under the auspice of Indian College of Anesthesia. Today we'll be discussing regarding the organ donation statements made by the Indian Society of Critical Care Medicine. It is a very important topic. There is a huge gap between the organs available for transplant versus the number of people who need transplant. So fill the gap, the Indian Society of Critical Care Medicine has come up with the recommendations, and they have also cited the strength for their recommendations. And there are extended criterias so that more donors can be recruited for organ donation. So I invite Dr. Ashwini Chaudhary to go ahead with the presentation.
Good evening, everyone.
You're audible.
Today we'll discuss the recommendations for the evaluation and selection of deceased organ donor. Organ transplantation is the only treatment modality for patients with end-stage organ failure. The huge disparity between demand for organ transplant and the actual transplant surgeries done is because of the determination of contraindication and failure to evaluate the donor. The purpose of Indian Society of Critical Care Medicine guidelines for organ donation is to establish the recommendations for multi-professional critical care staff in the evaluation, assessment, and selection of the potential organ donors. There are steps. The first step is timely identification and early referral of potential organ donor to staff coordinator. The first clinical trigger most of the time is the patient who has a catastrophic brain injury, namely absence of one or more clinical nerve reflexes, a Glasgow coma scale less than 4, which was not explained by sedation. The second step is intensivist lead monitoring the team role. In this comes the prompt application of the donor care bundle, more rapid assessment of marginal donor, and early tissue typing and virology screening. The last step is coordination, communication, documentation, and implementation. In this, the earlier stage information noted and discussion handled sensitively as per the donor family needs, and ICU team to coordinate with the donor coordinator and transplant team for the assessment of the expanded criteria for organ evaluation. There are two categories of the deceased organ donor. The first one is standard criteria donor. In this, the donor's age is under 50 years and donor who has suffered isolated traumatic brain injury or medical condition. The second category is expanded criteria donor. In this, the donor's age can be more than 60 and donor can have at least two of the following conditions like hypertension or cerebrovascular cause of death or pre-retrieval serum creatinine more than 1.5 milligram %. There are grades of recommendation. The grade A indicates benefits outweighing the risk. Grade B is benefit are likely to outweigh the risk, and grade C is benefits and risk must be assessed on case-to-case basis. The first few recommendations are for all donors. The recommendation one says early detection and assessment of potential brain dead donor. The first limiting step in this is refusal of consent by deceased donor's family. There is a link between information about the organ donation given to the family and the rate of consent given. And the second recommendation is communication be carried out in a private setting in a stepwise fashion with a temporal separation regarding notification of brain death acceptance by the family and request for organ donation. Trained intensivist plays a key role with donor coordinator regarding communication and obtaining a consent. Recommendation 3 is intensivists should aim to increase organ availability and adopt new approaches for screening and selection, which should be based on emerging evidence that permits the successful harvest of organ from the deceased donor organs that were previously considered unusable. Recommendation 4 is the intensivist should play a central role in evaluating the deceased donor. Intensive care unit team should obtain detailed history to ensure the cause of brain death. For the correct evaluation, biochemistry and radiological investigations are needed. The needed investigations are for all donors, we need to screen blood, urine culture, sputum culture, electrolytes, hemodynamic medications, and vasopressors. For organ specific donors, for kidney, urine analysis and biopsies if indicated. For liver, serum transaminases, alkaline phosphatases, and total bilirubin gamma glutamyl transferases. And for heart valid ECG, 2D echo, heart cardiac enzymes. For pancreas, serum amylases and serum lipase. For lungs, ABG and sputum gram stain culture. And recently added is COVID-19 RT-PCR. Screening for the infection and malignancies should also be done. If the donor is having severe systemic infection, like Listeria and Trypanosoma, or untreated or unknown origin infections, uncertain encephalitis with viral origin, febrile meningoencephalitis of unknown origin, active infection due to fungi or any other opportunistic organism, or infection with no treatment options like rabies, dengue within their infectious and transmissible period. Also, the donors with malignancies like metastatic malignant neoplasm, acute leukemia in progress, acute lymphoma, melanoma, pulmonary microcytoma, and multiple myeloma cannot be selected for organ donation. Recommendation 5 is blood cultures should be taken from the deceased donor. If the donor is having active bacterial infection, then the organism specific antibiotic should be given 48 hours before the organ procurement. And this information should be given to the transplant team so the recipient also receives the pathogen specific antibiotics for 7 to 10 days. ISCCM recommends the evaluation and for use of kidney for expanded criteria donor in selected cases. The dual kidney transplant is safe and effective if donor's age is more than 70 years. As per recommendation 7, ISCCM recommends dual kidney transplant from the donors above 70 years after meticulous evaluation and selection and communication with recipient whose outcome is poor without the procedure. As per the findings of a Hellman et al. Study, there is a significant opportunity to use the kidney from donors who had acute kidney injury and there is no significant difference in graft survival. Recommendation 8 is pre-implantation of tissue biopsy is in indicated cases to be confirmed and reported by specialist pathologist before organ refusal. The overrepresentation of glomerulosclerosis in veg biopsies is a problem even when the sample is evaluated by specialist pathologist. As per recommendation 9, in the absence of adequate data, ISCCM suggests balancing the risk of SARS-CoV-2 transmission, its potential effects on graft quality, and the risk to the procurement teams, with the recipient's risk of mortality and with the waitlist complications. For liver, the recommendation 10 is not to consider age limit as the criteria for the refusal of deceased liver donor. Liver from older donors should be accepted if selection criteria are fulfilled. As per recommendation 11, correction of sodium level if more than 160 but higher level is not a contraindication for deceased organ transplant. Hypernatremia is common in brain dead deceased donor. Magnus et al. Study reported no clinical impact of serum sodium on post-transplant liver function. A liver from deceased donors who are B serology positive except HBsAg positive and with evidence of resolved HBV can be considered for the donation in HBV carrier with the minimum risk and implementation of specific antiviral prophylaxis, and similarly HCV positive deceased donors can be considered for HCV positive recipient. ISCCM recommends against the using liver from deceased donor with HIV positive status. Recommendation 13. ISCCM recommends preferring a deceased donor liver transplant from brain dead patient over the donor with circulatory death. The recent meta-analysis reported no difference in patient survival between deceased circulatory death donor and deceased brain dead donor, but in deceased circulatory death, the was linked to an increased risk of graft loss. Recommendation 14 is RT-PCR testing test screening for COVID-19 in all deceased donors before elective and emergency organ transplant. Transmission of COVID from donor to recipient is possible only if the donor is COVID negative and recipient is from the same city. Deceased donor liver transplant should be carried out. For heart, uh, ISCCM recommends considering the age, comorbid condition, body weight, and morphological examination of heart in all deceased donors with the aim of including marginal donors before refusal. The characteristics of the deceased donors are for age, Registry of International Heart and Lung Transplant says that the median age of heart allograft has increased from 31 to 42 years. For gender, there is a negative impact was observed in male recipient who were more than 45 years of age and received a heart from deceased female donor. For allograft, the donor should be within 20 to 30 percent of weight, and donor risk factor. Donors having diabetes and hypertension both have vascular effects and negative impact on recipient outcome if the donor was male. No such effects with female deceased donor were observed. A donor with left ventricular hypertrophy and with left ventricle wall thickness more than 1.4 centimeter was associated with poor outcome. For deceased donor monitoring, both initial echocardiography and pulmonary artery catheterization guided assessment and management of potential heart donors should be considered as standard practices. Organs should not be refused based on the initial cardiac dysfunction on echocardiography. Recommendation 16 says that extended criteria donor to include the undersized hearts in selected recipients. For the evaluation of heart function before refusal, both initial and serial echocardiographic examination to be taken into account. ISCCM recommends against using the deceased donor heart with the documented left ventricular thickness more than 1.4 centimeter. These are the criteria for acceptable heart donors. Age should be up to 65 years, undersizing, oversizing up to 20% of body weight, prolonged hospitalization, history of chest trauma, elevation of myocardial enzymes, transient hypotension, wall motion abnormality, or cold ischemia time 4 to 5 hours. On long distance procurement, high dose press requirement, correctable valvular dysfunction by echocardiography, or bypassable 1 or 2 vessel coronary artery disease, prolonged cardiopulmonary resuscitation for 5 minutes, open cardiac massage, or persistent conduction disturbance. For lung transplantation, ISCCM recommends careful selection of extended criteria donor for lung transplantation. Donors who are old and chronic smokers should be strictly avoided. Multiple studies reported that donors aged between 50 to 70 years with absent or infrequent smoking showed survival non-inferior to the donors of standard age group. And the careful screening of history and CT scans for the deceased donor lung to rule out aspiration pneumonia before considering lung transplant is important. As per recommendation 21, ISSM recommends following individual institutional protocol with RT-PCR and HRCT to rule out COVID-19 in deceased donor. ISSM also recommends against the transplant from deceased donor with high pulmonary vascular resistance. For lung transplant, the donor criteria as the donor's age should be less than 55 years, ABO or blood group compatibility, clear chest radiogram, PaO2 more than 300 and FiO2 1 with PEEP of 5, less than or equal, smoking less than or equal to 20 pack year, absence of chest trauma, no previous surgery history on the side of harvest, no aspiration or sepsis, absence of purulent secretions at bronchoscopy, sputum gram strain free of significant number of bacteria or fungus. In expanded criteria, donor the age of the donor can be more than 55 years if the donor is healthy. PaO2 less than 40 on FiO2 0.4, smokers more than 20 pack years, absence of history of lung disease, and mild asthmatic donor. For pancreas transplantation, ISSM recommends a careful deceased donor evaluation with the age more than 55 years with morphological assessment prior to the considering the donor for pancreatic transplantation. Pancreatic transplant alone is an option in a diabetic patient with normal kidney function. Patient with diabetes and chronic kidney disease may need deceased kidney transplant or simultaneous pancreas and kidney transplant or pancreas after kidney transplant. Transplantation of islets of Langerhans in selected cases can be a good option instead of whole pancreas transplant. For intestinal transplantation, the donor's age for intestinal transplant to be less than 50 years with no history of blunt abdominal trauma, ICU stay less than 1 week, and serum sodium less than 155 milliequivalents. ISCCM recommends the careful selection with the evaluation of bowel length and functioning by CT enterography apart from the other tests. Intestinal tissue poses a large lymphoid load and immunological reactivity to the recipient. For the patients with irreversible intestinal failure with home parenteral nutrition, intestinal transplant is proved to be a cost effective. For cold ischemia time, ISCCM recommends that for kidney, the cold ischemia time should be less than 36 hours. For heart, it should be less than 4 hours. For lungs, it should be less than 6 hours. For liver and intestine, it should be less than 12 hours. And for pancreas, it should be less than 18 hours. ISS recommendation against COVID transplantation from the deceased donors with vaccine-induced thrombosis and thrombocytopenia at present in view of substantial lack of evidence. After COVID vaccination, vaccine-induced thrombocytopenia and thrombosis is typically occurs between 4th to 28 days, which resembles the heparin-induced thrombocytopenia with the production of autoantibody against platelet factor 4. If untreated, this vaccine-induced thrombosis and thrombocytopenia can be debilitating or fatal. High risk of thrombosis and bleeding in allograft has been reported in recipients when the donor was having vaccine-induced thrombosis and thrombocytopenia.
That was a very comprehensive presentation, Dr. Ashwini. Well done.
Thank you, sir.
Now I request the participants to come up with questions. You have any doubts or clarification, please go ahead. You can unmute yourself and ask the question, or you can put it on the chat box.
Good evening, sir.
Good evening.
Sir, what the transplantation of the pig's heart to the human, what it is called, sir? Is it so? It's popular. Why? Because recently they have done the transplant and the patient was there for 24 days and died. Is it? What is it? First of all, what it is called? From animal to especially the pig hearts.
It's probably a heterograph.
You heard about it? You heard about
it? Yeah, I think it was done quite some time back in India, in Northeast. But recently, I think the one you're quoting is done in USA.
Yes.
And it was genetically modified pig's heart. They were expecting it to do better, but I think this patient went into multi-organ failure and probably immune-mediated rejection, and the patient passed away. So I think probably some genetic modification has been done, but it didn't work out. The patient probably had a rejection and heart failure and some multi-organ problems related to that. So it's not well for quite some time.
We use valves.
Yeah, valves are probably say what happens
is the heart it can be withstand, or they are done only for experimental purpose.
Yeah, maybe I think probably it was a high risk procedure and the waiting time is so much. So they are trying different techniques. Genetically modified this thing, if it can be modified to same as the human this thing and the blood group specific, probably then it might work. Otherwise, I think
sir, it's called a xenograft, right, sir? Xenograft.
Yeah, xenograft. Yeah.
Because vasculitis and all is so common, it can't accept. So coronary vasculitis and all.
True. So the other thing about the donor, this thing, it was mentioned regarding different organs. What is the cold ischemic time and for different organs? Yeah, for the heart, it has to be as early as possible, or probably less than 4 to 5 hours of cold ischemic time is okay in case there are logistical issues. But quite a few times, if the the recipient is in the same hospital as the donor, you can actually do the harvestation in the adjacent OT and try to do it as early as possible so that the ischemia time comes down and the graft survival becomes better. That is one thing. And the moment you identify a donor, there are a lot of pathophysiological changes which happen in a patient who's brain dead. Few of them, to be specific, is the autoimmune disturbance, hemodynamic disturbance will set in. Even the electrolytes, hypernatremia can set in. Patients can have diabetes insipidus. The cortical dysfunction can also affect the other parts of the brain, and the adrenocortical system can fail as well. So these patients may need supplemental steroids, including methylprednisolone. Sometimes the pituitary gland fails, and they may need if you check on the T3, T4, TSH level, everything might be suppressed. So may need thyroxine replacement, especially if you are talking about heart transplant. It is recommended to give thyroxine replacement. In India, we give 300 micrograms through the Riles tube. The recommendation is to give it IV as an infusion, but unfortunately, we don't have it available in the country at the moment. And the other thing is diabetes insipidus is quite common in this patient, and that is detected the moment the patient starts, the donor starts passing more than 3 to 4 ml per kg per hour of urine, you should suspect that patient may be having diabetes insipidus. And the treatment for this is desmopressin. And for hemodynamic disturbance, the drug of first choice in this patient might be vasopressin. Previously, they were using dopamine, but now currently the recommendation is to use vasopressin for these patients if there's any hemodynamic disturbance. And of course, other agents like epinephrine, norepinephrine, and dobutamine can be used in these patients. Dobutamine may not be very effective. So this
in
is
infected cells like COVID and all can be donated, can be taken. COVID patients, heart.
I think the general experience with this is less.
Not.
In case you have a patient who's initially COVID positive and then his serology has become negative, in that kind of a situation, they have tried doing renal transplant and a few other transplants, but the experience is not very great. And later stage, once the patient is serologically negative, maybe the chances of infecting the transplant team or the harvest team comes down significantly, and it might be feasible. And the other problem with the COVID is because of the pandemic, the number of organ harvestations became significantly low.
Yes.
So that was another major problem. A lot of recipients who were waiting for transplant,
especially
they had a major problem because the organ availability was a problem. And during this period, in case you're on dialysis, reaching the hospital, quite a few patients got infected and had poor outcome. A lot of patients who are on dialysis, they couldn't reach the hospitals or they got infected and they landed up on ventilator.
Ischemic time, see homograft and all, we keep deep freezer homografts, aortic grafts, like that. Is it possible for the heart to defreeze very much?
No, I think the tissue, the heart, these are relatively live tissues. When you're talking about homograft and valve, they are probably ischemic tissues. And blood circulation is not there for these tissues. They just act as a scaffold, whereas heart has to be live and the myocytes and all should be functioning. So
because myocytes and all, because of this one cooling of the temperature hibernating like.
That deep freezing technique, what we are using for vascular purpose and for valve, this thing is different. The heart cannot be preserved that way. I think there are some intermediate techniques where people have used eCPR and in the process the other organs stabilize, but the heart, if that is the reason for cardiac arrest and you've done eCPR, probably heart will not be available. People have tried extending the duration by actively perfusing the coronaries and in a protected environment. Those technologies have been used, but I think they're all still experimental. Best would be to do it as early as possible, and maximum of 4 to 5 hours. People out of desperation have tried for even an extended period of time, but then again the results are the graft survival comes down significantly.
Like a VAD, any artificial heart like pumping. I heard, read one article, but I'm not remembering.
So I think in case patient is in low cardiac output and waiting for heart transplant, a lot of devices are available as bridging, including intra-aortic balloon pump, impeller, HeartMate 2 can be used as a bridging LVAD, HeartMate 2 that can be used as a destination or as a bridge therapy for transplant. And short-term, this thing you can use Centrimag as a bridge for transplant, but we are not.
No permanent, like means no extended time cannot be.
Sir, there is one question have been raised, sir.
Hello.
Yes, sir. There one question have been raised from Dr. Avnish.
Okay.
How is your experience with pancreas transplant in Indian perspective, please? This is the question by Dr. Avnish.
At Narayana, we have done a combined kidney and pancreas transplant. But sorry, I don't have personal experience with that. That
Dr. Avnish, if you have any further queries, you can ask.
Yeah.
Okay, sir. Like any other transplant, like bone transplant, intestine transplant, like is it possible in India? Like I didn't heard. That's why, sir. This is like
this
very
is
encouraging
hand
to.
transplant. Yeah, hand transplant and has been done.
Sure.
And that is quite a success thing. You have to fix the bone, then the arteries and the vein, and at a later stage, you can fix the tendons. So that has
Okay.
been done multiple times, and with a fair bit of success.
Okay, sir. What about ABO incompatible transplants in heart, sir?
See, I think that is this has been tried with the kidney. There's not a big experience with the this one heart transplant. Heart transplant, I think at the moment the only thing which they match is the blood group. So if you have a AB recipient, then he can take any group. O can donate to anyone, but it has to be matching. The blood group has to match. Otherwise,
Okay.
it is not possible.
Sure. Okay.
Whereas
Okay.
the kidney, they have tried across the blood group, and there's quite a bit of success actually there.
Okay.
With heart, I think the blood group matching is critical.
But cornea, doesn't record any this one. Cornea.
Yeah, cornea has a avascular structure. For that, you don't need actually. So by doing plasma exchange across the blood group can be done for kidney. I'm not sure about the liver. The liver also it should be possible, but heart because the time available is very less, and it cannot be a planned procedure. It has to be done as an emergency. So heart it is not possible. Whereas kidney you can extend it up to 18 to 20 hours or even beyond that. So you can do all the HLA matching and whichever is the closest match, blood grouping, and if it is a live donation, related donation, then you can do it across the blood group as well. But with the deceased donor for the heart, it is not possible to do across the blood group.
Okay. So, what is your experience with left ventricular support devices, and after the like bridge to transplant, then doing transplant? Like, what is your experience?
We have a spectra of therapies for patients with the left ventricular failure, including patients with aneurysms and mechanical problems. For aneurysms, we do DOR procedure. That improves the function significantly. And we have had quite a bit of experience with the left ventricular assist device. These patients had poor LV function to start with, and we have been able to wean one patient from the LVAD, and there was some LVOT outlet obstruction, there was clot formation. Later, we saw that the patient's LV function had improved. So we just explanted the LVAD after 3 years. So this patient is doing well. And there is one more patient who had LVAD, and then there was mechanical failure, there was obstruction. So he had a LVAD as well, and because he didn't have to take immunosuppression, even though we offered him a heart transplant, he didn't opt for it. And so the LVAD, the HeartMate 2 is what we have used it, and there's a fair bit of experience. We have had patients surviving for 8 years. Initially, of course, they need anticoagulation, but subsequently, I think once the endothelialization occurs, they don't need that as well.
Okay.
Yeah. So the other challenges with the organ donation is the team which is managing the primary care team. They should not get involved in the coordination for organ donation. They should have a separate team which does talking to the relatives, so that the relatives don't become suspicious. We just tell them that the patient is the primary care team just has to inform regarding the brain death, and subsequently leave it to the coordinators to take care. And of course, brain death declaration is another detailed job where multiple people, including the intensivist, administration, and then the neuro specialists, they all have to participate in certification. And once that is done, they just inform the coordinators. They do the subsequent job.
So do you routinely recommend this thyroxine supplementation for brain dead donors, sir? Like,
See, I
what is
don't
your
have
institutional
personal.
practice?
I don't have personal experience with the donor. We have managed a couple of patients where we were basically doing heart transplant. So the before the harvestation of this thing, we got around 48 hours. So we did give them altroxin. I'm not sure how effective it was, but the general recommendation by the American societies and all is, in case you are planning for a heart transplant, it's better to supplement with the IV altroxin. Initially, bolus followed by continuous infusion. And the other thing which is recommended is methylpred and plus minus vasopressin depending on the hemodynamics.
And any specific pediatric heart transplant, sir?
Sorry, no experience with pediatric. But I'm sure that it will be something similar. Only thing is they're matching the size should be very important. So if you have 20 to 30% mismatch, then I think it is feasible. Beyond that, I think it will not be possible to do a pediatric transplant.
Thyroxine.
Professor, any other questions, sir?
Previously, they used to give thyroxine. Even all the patients who are coming difficult in coming out bypass, thyroxine
Yes,
is a good inotropes, and also so it modulates the myocardial cells so that it enhances the functions. They used to try. Next is later in the end, difficult coming of bypass. We used to give crush and we used to give thyroid. That used to help.
Okay. We have used one patient, I remember, who went into hypothyroid coma, where we used T3, which we imported IV, but this patient had probably we gave it pretty late. Though we were giving oral through the Riles tube, it didn't help. So we tried IV. This patient had a poor outcome actually. This was in the post-operative CABG patient. So this patient is the only patient I have tried IV T3. But I've heard that people in UK and all, they quite regularly try IV thyroxine for patients who failed to come off CPB, apart from the other inotropes being used simultaneously.
You've done this one for pediatric heterologous heart transplant.
So no
Patient
experience there, sir.
maybe heart will be there, the donor's heart is fixed. How does it, what is the principle? I don't know. How does it coordinates with the patient's systolic and diastolic?
I got no experience there, sir.
Because they fixed in the chest cavity, and this will announces the so is it theoretical or whether they have done it?
No, I have not had that experience, sir.
Okay, it's nice discussion today. She has spoke
Yeah, I
about
think,
spoke the entire recommendations, newer guidelines in the transplantation of heart, lung, and also liver, and this pancreas also, kidney
yeah.
and pancreas.
So the idea of having this class, this particular topic was to make sure that all our cardiac anesthesia colleagues, they're aware of what all things are the recommendations, and the other thing is how to manage these patients once they're in the ICU, how to support the hemodynamics, how to use the inotropes in this patient, and what are the other supplements these patients require. Most of the patients, because of diabetes insipidus, they get hypovolemic. So volume, especially crystalloids are recommended. And other than that, I think vasopressors, taking care of the electrolytes, because a lot of autonomic disturbance is there. Arrhythmias can set in, especially tachyarrhythmias can this patient can go in for tachyarrhythmias. So taking care of potassium, and the other problem is the sodium might go very high once the patient is brain dead. So that needs to be taken care as well. So we should know how to take care of patients in case they are potential organ donors. Fine, sir. In case there are no other further questions, shall we wind it off, sir?
Yes.
Yeah, we can do the conclusion, sir.
Yeah, I thank Dr. Ashwini Chaudhary for today's newer topic for us, for everybody, newer guidelines in the transplantations of all possible organ this donation, like heart transplantations, liver, kidney, and lungs. And we had a nice discussion also. I thanks Dr. Ratan Gupta and Dr. Kanchi sir. Kanchi sir is there. Whether Kanchi sir is there? He was tired of attending this one. And also I thank Rajiv for his support for today's class. Thank you.
Thank you, sir.
Thank you, sir.